participation in the meeting. We're going to go ahead and transition to the first panel. So we're going to continue to discuss some of these key issues with regard to the epidemiology and the clinical manifestations of the virus that Dr. Chertow touched on, and talk about how across our institutions we are dealing with the care and preparations and management of safety of our clinicians during this pandemic. So we have a wonderful panel this morning. I'll introduce each speaker in turn, and we'll kick off the panel this morning with Dr. Roberta DeBiasi. It's my pleasure to introduce her. Dr. DeBiasi is Chief of the Division of Pediatric Infectious Diseases and co-director of the Congenital Zika program, and co-lead the Ebola and highly contagious infectious disease institutional preparedness program at Children's National Hospital Center. She has been on the forefront at Children's of leading the response and preparations for this pandemic, and actively involved in thinking about how to prioritize and coordinate research initiatives. So Dr. DeBiasi, thank you very much for making time to be with us today, and we look forward to your remarks. Our team will help advance the slides on your direction.
Great. Thank you so much for inviting me to participate today, and I really enjoyed Dan's talk, so thanks for that. Looking forward to the panelist interaction as well. So, you know, this is just a dashboard that we kind of go over at least every day at Children's, just to keep an eye on what things are going on. And, you know, the take-home point here, I don't know if you all can see my pointer, is that, you know, over the last several weeks, we're seeing this steady decline in the rate at which the cases are increasing. It doesn't mean that they're not continuing to build up, but that the rate at which they are increasing has declined, meaning that we're sort of at the top of this roller coaster hill in the areas where this has been an issue. And I'm just highlighting here our region, Maryland, Virginia, and DC. We've had 24,000 cases with now about a 5% rate increase per day. And if we contrast that from 3 weeks ago when we were peaking out at a 30% increase each day, we clearly do seem to be hopefully getting to the top in the next week or so here in the region. We've had 4,600 hospitalizations and 921 deaths. And our case fatality rate here in the region is at 3.8%, which what we've seen in other places is as the cases evolve and the epidemic in that particular area evolves, of course, the case fatality rate will generally increase as the patients that have been hospitalized then declare themselves as either recovered or not. So if we look at the US as a whole, there's an overall 5.3% case fatality rate, which is very high compared to what we're used to with influenza. And I'm sure all of you on this call are aware, but for instance, the 1918 pandemic had a case fatality rate of about 3%. So this is very high. If we look globally, it's almost 7%. And in areas in Europe, such as Italy or Spain, they're as high as 12 or 13% in some of the areas, likely reflecting an elderly population, but also the fact that those areas had healthcare systems that were very overwhelmed with a peak surge. Next slide. So at Children's, we've been preparing for this like every other hospital. You know, although the initial epidemiologic reports out of China, as well as some reports out of Europe, showed that the pediatric population is relatively less affected than adults, making up only about 2% of all the severe cases. We still, of course, have cases and need to be prepared to take care of these children and young adults. So we've had, this is now up to 111, but we've had over 100 positive children, 30 have required hospital admission, 22 in our basic special isolation unit, non-critical status, and 8 in our critical care status. The age range has been anywhere as young as a month of age, all the way up through 25 years of age. We take care of patients all the way up through age 30 in this pandemic. regional plan, we've seen about an equal split of male and female, and we've only seen underlying conditions in about half of the patients, slightly higher in our critically ill patients, and they are very similar to what is seen in adults, but also some that are more unique to pediatrics. So we've had sickle cell, some children with microcephaly and static encephalopathy, global developmental delay, trisomy 21 with cardiac defects, and then of course other respiratory issues like asthma, and then other known risk factors such as obesity and hypertension. Next slide. This is just an interesting, in contrasting with the adults, we seem to see a bimodal distribution. So in blue are all positives, in red are the hospitalized positives, and then in green are the critically ill hospitalized positives. And it's very clear that the very young and the older children and young adults are disproportionately the ones that are hospitalized or critically ill. And this is not surprising, I think, from the 16 to 25-year-old group, since that's the pattern that's also seen in the adults. But there is this cohort of younger children that often have a sepsis-like presentation presenting with COVID. Next slide. So this is just, really just a shout out to the pediatric ICU teams who really have stepped up to take on older patients for us. They're the younger patients for the adult hospital, so these are the young adults up to age 30. We have experience doing this because of our programs with congenital heart disease, cystic fibrosis, etc., underlying illnesses where we know these people from childhood and then continue to follow them. But this is a new model and actually a historic time at Children's where we actually are admitting previously known patients to us that are in this age group. And it's been a very good effort from all of the critical care staff. Next slide. So I just want to go over a little bit. I was asked to just comment on how we've prepared and what we've been doing. And this is just a very high level overview. So we have much expertise in emerging infectious disease at Children's. We've had a track record as a leader in emerging infectious disease, particularly for pediatric response. And that goes all the way back to anthrax in 2003. In 2014, during the Ebola outbreak, we were designated as a treatment center and have maintained that funding from HHS to remain prepared and have special teams that continuously drill. We have a special isolation unit that actually provides us with 3 zones of 60 negative pressure beds in a very safe environment. We're building a satellite lab in that area. And then in 2015, we responded with one of the first congenital Zika programs in the country and are following 2 cohorts, one here in the US and one in Colombia, about 100 women infant dyads there long term, and offering them care as well as research projects there. In 2016, we've been very involved with acute flaccid myelitis, both with the task force internally, but also the national and international working group. And then in 2018, we've kind of expanded our pediatric Lyme program. So we've always had an active pandemic emergency plan at the hospital, and this has been for many years, and this is reviewed annually. And so it's sort of been there, ready and expecting for this to happen, like any other group that follows emerging viruses. So we were clearly not starting from a 0 level when this occurred. Next slide. So, from December to February, we are, of course, we're in infectious disease and infection control, always tracking these things and watching this, informing leadership of what we thought we needed to do. And then we really decided to activate our incident command structure, which is part of our emergency response in March, end of February, beginning of March. And this has really continued now through this time where we have daily COVID task force calls, which are hospital-wide representation. And then we have a smaller steering committee call each day as well that keeps everyone updated and pushes forward what needs to happen. Our first patient was on March 15th. And then, of course, like every other hospital, we're continuously changing our plan and augmenting it depending on recommendations from the CDC, the White House Task Force, other federal agencies, and the World Health Organization. And, this has been a challenge. It's very hard for staff to not only deal with the new virus, but then have to deal with changes every 3 to 4 days with what we're doing. Next slide. So, our guiding principles have been staff safety, number one, patient safety, number two, and managing our surge of potential volumes for the community to make sure we can not only meet the demand for the COVID surge, but maintain our ability to care for our children who really have other complex medical issues that are not going away during the COVID pandemic. Next slide. So from the clinical care and operations standpoint, personal protective gear and supply chain are paramount, and you've heard about this on the news every night. We actively manage all of our supply chain very closely, including not only the personal protective equipment, but also our ventilators, our other pharmaceuticals for the hospital, other patient care supplies, disinfectants. That's really a more than full-time job for many people to manage this. We monitor our PPE inventory and burn rates very closely and make sure that we are not exceeding what we want for our targets before our projected peak surge. We have PAPR acquisition as much as we can because these are all on back order, but we have a good supply of these respirators that can be used in our ICU and our surgical teams in particular. And then we have been in PPE conservation mode for at least a month, where we have implemented things such as CDC approved ways to extend the use of PPE, cohorting our patients so that we're not necessarily changing PPE with every patient, which also extends the use. We have an active UV sterilization program for our N95 masks, and then we have universal precautions for our staff. Next slide. So this is just an example. We have special signage that goes on all the rooms so that there's a clear visual for people at any, whether they're environmental services staff or any part of the hospital, will know immediately that this is a room that needs to be different personal protective gear and handling of the patient needs to occur. And we have clear visuals for how to don and doff for safety. Next slide. And then we have a very large group planning continuously for that has been going on for the last month and a half, surge planning. And this is really a regional approach. So our hospital is a 323 bed hospital, of which almost half are critical care bed capability. And we have over 106 negative pressure rooms, which is really quite high, mostly because of our special isolation unit that can be expanded in a zoned way if need be. We use all sorts of modeling to calculate our surge capacities, and this is also includes conversations with our regional partners. So for instance, we have expanded, as I've mentioned, our ability to provide for both COVID positive young adults that are up to 30 years of age, which then of course frees up other adult ventilated beds in other hospitals for older patients that we would not take care of. And also helps with the healthcare workers that can take care of those patients in the adult hospital. We work really closely with the District of Columbia Health Association, as well as all of our local health departments to work on surge planning. And we also have liaisons from the Department of Health that come directly to our hospital. Next slide. We have instituted screening of our visitors and staff for many weeks now. We purposefully want to reduce the number of visitors, and particularly because we know about asymptomatic carriage. So, trying to detect who's sick is certainly important, but we'll still miss people coming into the hospital and potentially infecting staff and other patients. Because we are a pediatric institution, we still do allow one visitor, but it's under very restricted ways that they are allowed to be, and certainly not move about freely in the hospital. We've canceled many elective surgeries and have converted many of our outpatient visits to telehealth. And I'll talk about that on one of the later slides. And we also have symptom and temperature screen of all of our employees, because you can have a low-grade temperature and not even realize that, and we don't want to have those employees potentially infecting other employees or staff. We also have a very robust cloth mask program through philanthropy and donations. We have over 30,000 cloth masks that we've now distributed to patient families, and the CDC has had recommendations that while we're very clear these do not substitute for PPE for our staff, they are recommended for community members to use, in particular patients. For instance, if they're a visitor or a parent, they can wear the cloth mask as they enter our building, and also if they're interacting with any of our healthcare providers in their room. Next slide. Our lab response has really been phenomenal, thanks to Megan Delaney, who's our lab medicine and pathology director. So we were able to implement rapid in-house testing very early on with a 3-hour turnaround. We can test patients, we test symptomatic employees as part of our occupational health program, which really allows us to figure out what to do with those employees very quickly. We've had over 1,500 patients we've tested to date, and now have further ramped up our preoperative screening. So these are patients that are asymptomatic but scheduled for surgery. We can do quick testing on them to guide our surgical staff on where to do the operation and what sort of PPE to augment if needed, or to defer a non-urgent surgery if the patient is found to be positive, and we certainly have found that. And then we're now expanding to test all of our admissions as our lab capability has ramped up. We also were instrumental in setting up the first pediatric ambulatory drive-up or walk-up test site, and this was done about a month ago. We've now tested about 750 folks that are basically referred in from their primary care physician. So these are generally symptomatic individuals who are of milder disease that is not warranting a trip to the emergency room or certainly not needing hospital admission. And we've gotten very interesting trends for looking at sort of how this is moving through the community based on our rate of positivity from that site. And now we're, as Dan mentioned, serology is certainly going to be important, and we're bringing that online in the next week, important for our recovery phase. Next slide. So part of this is constantly changing, but updating and educating our staff about how we're going to apply testing and isolation. And the point of this is not for you to read all the parts, but it's complicated. So, you know, for instance, the people that we consider a PUI has drastically expanded over the last month. So it used to be very discrete criteria. Now it's basically anyone with fever or respiratory symptoms or anyone who's critically ill. And then we guide them as to what they need to do specifically about what PPE to put on or not, where they will be designated for admission, which we try to cohort in our special isolation unit or our PICU, rather than having people spread out all over the hospital. And this is constantly changing. Really almost every 4 to 7 days, there's a change in some way in this algorithm. Next slide. We've also, as I mentioned, really capitalized on telehealth. And, you know, for years we've done telehealth at Children's, but you may or may not be aware that there are many regulatory hurdles to telehealth that make it difficult to scale it up quickly on a large scale. And frankly, we've been a little bit frustrated by that because our patients love it, we love it. It's very effective, particularly for special needs children who it's very difficult to get them to and from their homes. And for many visits, it's really not essential that they would be in person because you can do a lot of the physical exam by telehealth. So really the one probably silver lining of this pandemic is this ability to rapidly convert and upload the amount of telehealth that we can do. And it's sort of been a proof of principle that we've been itching to do it, and the patients have really enjoyed it. So we've now converted about 70% of all our ambulatory visits to telehealth. And we went literally overnight from less than 50 providers doing telehealth to over 800 providing telehealth. So I think it's going to be really interesting to see what happens in the post-COVID era if these regulatory barriers are lifted and we can continue to expand this to individuals for whom it's appropriate, because I think it's really the way of the future for many types of patients. Next slide. Occupational health, you know, we really had to expand our occupational health staffing. Many employees that were actually not furloughed but put on in other words, as the hospital volumes went down, there's a smaller need for some staff, but they can be redeployed for other very essential and critical roles, and occupational health is one of those. So many of the nurses that were not needed for their usual roles could be redeployed to help with occupational health. And we have a very robust program where managers and staff know immediately to report any symptom, no matter how mild it is, and immediately get a response from occupational health to put on a mask and either immediately go home or not, and then within a day have our in-house rapid testing. We have a very clear algorithm that this expanded team of nurses can deploy so that it's a standardized approach to our patients. And then we also have lots of wellness initiatives because, as Dan mentioned, this is an incredibly stressful time for staff. So for instance, there's virtual meditation sessions that are available to staff twice a day. There's augmented child and elder care solutions that have been brought on board by the hospital because, you know, people have kids at home now that are not going to school. So these are all things that are important for occupational wellness. Next slide. So human resources is another whole issue. We've actually had contingency workforce plans to include possibility that you'd have a drastically reduced workforce. We're very happy we've not had that. But that is always a possibility. We've also had to manage family medical leave and vacation time. We've greatly expanded telecommuting options because that is safety for staff and patients to have as few non-essential staff in the hospital as possible because, again, they are out in the community and can bring that into the hospital. And then we have had a program for exclusions, for instance, of elderly care providers or pregnant women who wish to apply for exclusion from care of COVID positive patients because those are recognized risk factors for severe disease if that employee did acquire COVID as part of their occupational exposure. Next slide. And then communication and education is a huge part of this, keeping all of the hospital on the same page. So we have a COVID-19 intranet hub. Basically has almost any possible answer to any question, any document or procedure is all housed in this one area. We have FAQs that when we answer, we post to this area too so that other staff can benefit. And we also have online training videos for personal protective gear, isolation procedures, etc. We had a similar model when we have measles outbreak. We had a similar model for Ebola. So the staff at our hospital is very used to this concept of having a centralized place for our response. We have town halls 3 times a week for staff and managers and have usually over 800 to 1,000 people on these calls. So there's great interest in this. People are very eager to know what is going on and be on board with the latest changes. And then we also have targeted town halls, for instance, for our nurses or anyone who requested, our respiratory therapists who have more specific questions about things. And this is participated in by all of our hospital leadership as well as designees from the steering committee so that we can address any questions that come up. Community education is also important. So we have a very large children's network of primary care practices that are affiliated with our hospital, and we feel it's our duty to also include our education to those practices. So we've worked very closely with them to give them guidance for their practices as well. Next slide. And then, you know, countermeasures, of course, Dan has talked extensively about this, but we've developed clinical care algorithms for the pediatric population, which of course is another whole can of worms because some of the protocols, although we can get agents on EIND, there's not a specific protocol that pediatric patient can be involved in. I will highlight we have a convalescent plasma program at our hospital where we actively can make convalescent plasma, and we've done this for one young adult patient who tolerated this very well, and of course, you know, who knows if it was related or not, but is now doing well. And we have donors that are actively donating so that we can screen and have product available. So that's been an exciting program and may have more implications for our immunocompromised population. Next slide. I think this is my last slide. So, you know, research is also a very important part of what Children's does and our Children's Research Institute. And as many of the labs have been put on hold, of course, it gives an opportunity for those labs and their expertise and techniques to think about how they can contribute to research related to COVID. So these are just some of the things that are going on at Children's. We are building a centralized, de-identified institutional database that will have all of the validated data across the hospital, because of course each of us have clinical databases or research databases that are targeted for specific questions, but this will be a unified, de-identified database. We also have, through our CTSA, have built a wiki that will catalog all of the COVID-focused projects and also get a handle on what resources and specimens that each project would like, so that we can align with each other what we're doing, collaborate, and also make best use of these limited clinical specimens. And some of the interesting projects, but not at all a complete listing, include projects that are interested in looking at the genetics of COVID, T-cell therapies to treat COVID, the fetal-maternal interface, and particularly how this affects the newborn and neurodevelopmental outcomes, and then diagnostics, including a variety of rapid point-of-care diagnostics. And we work very closely all the time with our government affairs office partners to identify federal appropriations that can then support this research and response. And I think that's the last slide, but let's see if there's one more. Oh yeah, the path ahead. So, you know, there are many challenges as we move through this acute phase into the recovery phase. There's certainly been, and this is not unique to Children's at all, but there's a huge financial implication, lost revenue, because of our really need, of course, to decrease the amount of non-urgent surgeries and admissions. We hope that will improve as we get into the recovery phase, but that's a major problem. We have to be able to stay financially solvent to be able to provide care to children after this pandemic. Maintaining supply chain, PPE inventory, contingencies, as we've mentioned, if our modeling is not correct and we have a larger surge than we had planned. Contingencies if a large proportion of the workforce is ill, but we have not seen that, thankfully. And then, of course, maintaining the safety of both the employees and the patients as we move into the recovery phase and start to open up more surgery and admissions. And really serology and molecular testing hand in hand are going to be a big component of that. So I think I'll end there, and I'm happy to take any questions and really eager to hear about from the other panelists what their response has been.
DeBiasi, thank you so much for an excellent and informative presentation. What we'll do is we will let each of our panelists present, and then at the end we'll we'll open up for Q&A for each of the panelists. So thank you for a great start. I'd like to introduce Dr. Marsha Fermani. Dr. Fermani is currently the Director of Medical Laboratory Services at GW University, and brings to the COVID-19 pandemic experience from her work at NBAC, where she focused on biothreat agent characterization. Thank you very much, Dr. Fermani, for making time to speak with us this morning.
Thank you so much for having me here today in this panel. It's my pleasure to talk to you this morning. And my talk is going to focus on some of the ways that George Washington University has tried to minimize the spread around the campus and the impact that COVID has had so far at GW. So next slide. So in order to minimize the spread, GW is, a little bit different than Children's from the previous talk. Children's is a clinical facility, hospital-based, whereas GW is, a relatively larger university. There are a lot of students on campus, a lot of faculty members, staff members. So trying to minimize the spread very rapidly. How this was done was that all students were instructed to leave the campus and not return after spring break. And of course, some students could not leave campus, and so measures had to be put into place to allow students that couldn't leave campus to remain on campus, but to remain safely. So spring break was March 16th to March 21st. Students typically leave campus. So from March 16th on, we have not had any students on campus. So all of the campuses, all of the classes were converted to an online format immediately after spring break. And so, you know, there are some online programs where, you know, this didn't have a major effect on those programs. However, for face-to-face programs, all of the face-to-face teaching, this was a major effort to convert all of the classes that they would normally teach online within a 1 week period of time to convert them face-to-face, to convert them to an online format. And, you know, a lot of the faculty have never taught in an online format. So that I would say is one of the major endeavors that has taken place, and this had to happen very rapidly. Of course, you know, the leaders across campus had to start making contingency plans to, you know, determine what's going to happen for the remainder of the spring semester, what are we going to do in the summer semester, and we're now that, you know, as we've heard, this isn't going to go away, so we have fall contingencies as well, and I'm going to discuss some of those. There were plenty of conferences, workshops, programs, etc. that were scheduled for the spring semester as well as summer, and all of those have been canceled on campus, and all, if they can be, have been converted to an online format. Very quickly, the leadership at GW canceled all GW-related travel. So if anyone was traveling for a GW reason, they were encouraged to cancel their travel. And individuals that were traveling for a non-GW reason, if they could not cancel their travel, then they were asked, if they did continue their travel, to self-quarantine for 14 days when they returned to campus. Next slide. So for the spring semester, so starting on March 23rd, every single course was converted to an online format, and there were absolutely no on-campus courses being taught, and that has continued through the spring semester. So we are actually right in the final weeks, right before final exams on campus for our spring semester. So the entire semester has been online. Any programs or courses that could not be taught online, such as laboratory courses, these, you know, the program directors for these programs and department chairs had to very rapidly determine which courses can be moved to a different semester, so that, you know, any course that could be taught online. So programs of study had to be quickly rearranged if possible, and we've had to get very, very creative. So, you know, I'm actually the chair of the Biomedical Laboratory Sciences Department at GW. We have medical laboratory science programs, and of course we have laboratory courses, and in order, we were in the middle of some lab courses, and we had to convert those. So, you know, just finding virtual laboratories, and we had to pay a company to use virtual simulated lab experiments and things like that. So, you know, some of the things we had to do pretty quickly, and trying to be quite innovative in how we continued with our courses, because we didn't want to delay any of the students' programs of study and make them not graduate when they were supposed to. Our May graduation on campus, which is a large event at George Washington University. Each school has their own graduation, typically on Saturday. On Sunday is the large university graduation on the National Mall, and all of the graduations have been canceled. However, schools and individual programs are holding virtual graduation just so the students can participate in graduation. We're doing virtual awards for students, and all students that are supposed to graduate this May have been invited to our graduation ceremonies next May in 2021. Next slide. So for summer, we weren't quite sure what we were going to do for summer, but it has been determined that all summer courses have been moved to an online format. Students have not been told not to return to campus for the summer. So all students are going to continue with online courses. And for on-campus summer programs, they have either been canceled, postponed, or modified to an online format. So, for example, there's numerous summer programs that are held on campus. There's a lot of high school summer programs, and those have either been canceled, or we have, again, tried to get very innovative and hold all those programs online as much as possible. So we're not, stopping everything. Next slide. So for the fall, these plans have not been finalized, but some contingency plans that we've discussed are to, continue teaching online if possible. So trying to get, as few students all on campus and in the same rooms as possible. Possibly starting some classes late to allow international students to travel to campus, because there have been international travel bans. So students may not be able to get here. We, again, don't want to delay them. Limiting the number of students in the classroom. So when we do start on-campus classes again, which hopefully will resume in the fall, the contingency is to limit the number. So there will be no classroom that will be allowed to have greater than 25 students in it. Requiring PPE, such as requiring all students and faculty to wear masks. Social distancing required. So having students not sitting, right next to one another. So having 6 feet in between each student within class. And that's not easy because, we're limited on what classroom space is available, and trying to organize which classrooms need larger spaces because, you have a full 25 students to get them to be so properly social distance. Cleaning all high touch areas, that's been being done. So while many of us can, work remotely, those individuals, clinicians, people in the hospital, and, just people that, just normally clean the buildings have to be there cleaning all of the high touch areas. That's been ramped up. And of course, once we move back to some campus classes, that will again be ramped up greatly. The thought process is, as was discussed in the keynote, that possibly there's a seasonality to this. We don't know, but as temperatures start to drop, we could see another surge of infected individuals. So the discussion has been possibly, if we're on campus in the beginning of the fall, that we would convert to a fully online format again right after the Thanksgiving break, if that's necessary. So again, that's just a contingency that hasn't been finalized yet. And some programs I know, such as the programs in my department for on-campus courses that we're planning in the fall, our laboratory courses, we are going to be doing temperature checks of all students, as well as the faculty will be doing temperature checks before anyone is allowed to enter the classroom, just as another measure to try to minimize any potential spread of the virus. Next slide. So information dissemination, you know, that can be very challenging at any large institution. So and I'm going to apologize, my cat is screaming in the background. This is one of the main issues with working from home. So all schools have been sending out emails to their faculty, staff, and students with relevant information very regularly. There are various websites that anyone can go to at all times and find information on COVID, on, you know, what is happening on campus. Specific subsets of individuals are being emailed individually by program directors, by department chairs. So for example, you know, I'm sending out very specific email to my faculty just to keep them informed on, you know, what the plans are, what we're doing, you know, what we might be doing. Specific students, so for example, you know, students that are in clinical rotations, that's a specific subset. Not all students at GW are doing some sort of rotation or internship, but those specific students are getting individualized, very specific emails to them so that they know exactly what they need to be doing to get these, you know, internships and field work, rotations completed. Next slide. There have also been numerous town hall meetings. The first town hall meetings were, at least the first one was done face-to-face. There was a face-to-face element to it, but they have all been converted to an online format through either Zoom like this or WebEx. And these town hall meetings have numerous experts across the region discussing the virus, the outbreak, how to prevent it, things like that. There's been numerous question and answer sessions for you know, faculty, for staff. There have been many grand rounds for the clinicians focusing on various aspects of COVID. There's a GW Health resource page, and there's also a wellness resource, and some of that wellness information comes out for, you know, meditation and contacts for any type of, you know, stress or mental health issues and things like that that have generated from this pandemic. Next slide. So the clinical impact, of course, we have a lot of clinical programs on at GW's campus. We have the medical school, we have physical therapy, we have physician assistant, we have medical laboratory science. So there's a lot of different clinical programs. The programs that have where students do rotations that don't have any direct patient contact, those individuals have been allowed to continue with their rotation. So for example, the medical laboratory science students in my programs have been able to continue the rotations. We have restricted any voluntary direct patient contact for our students, but their mandatory rotations don't include direct patient contact, so they're allowed to continue with their rotations. Students that have direct patient contact, clinical programs, those they were suspended. Those rotations were suspended in the spring semester. However, students are now going to be allowed to go into their clinical rotations, but students are not going to be allowed to have direct patient contact with known COVID patients, just to try to minimize any risk for students. And of course, all students that are in rotations, even those like the med lab sciences where we wouldn't normally be wearing masks while we're in the laboratory, on a day-to-day basis, they are, using PPE, wearing masks, and, following all of the safety protocols for the facilities that they're working in. Next slide. So now a major clinical impact for us, and I'm sure for many, many other clinical programs across the country, that a lot of facilities suspended their rotations for students. So even if students were allowed to do the rotations, the clinical site said, no, we're not allowing anyone to come into our facility right now. We don't want to risk them getting infected. We don't want to risk them bringing in a potential infection and, getting our healthcare workers that we need infected and getting any potential, patients or visitors infected. So a lot of places across the country have suspended their rotations, which does have a major impact on our clinical programs, since students are required to typically by accrediting bodies to continue with, to have a clinical rotation. And so those have been postponed. Some programs have been able to move things around or develop expedited rotations or provide some alternate formats like virtual simulations. However, some have had to postpone, and so those students will likely have to delay their graduation by, we hope, just one semester, so that they can get back into the rotation starting in the fall and complete those so they can graduate. Of course, another issue across the country has been a lack of PPE, specifically masks, and a lack of enough tests. So, that's just an ongoing problem, and that's another reason why a lot of clinical sites suspended any type of rotations. There have been COVID-19 tests developed that many research are using, but of course these tests are testing for various aspects of the infection. And so, we're not getting, possibly the correct data that one might need to answer specific questions based on a lot of these very newly and rapidly developed tests that various labs are doing. Now, the clinical labs in the hospital settings, they're all doing FDA approved molecular testing for COVID. I know GW Hospital implemented very rapidly an approved molecular test for COVID. GW Hospital also very early on closed all of their entrances to the hospital, prohibited anyone from entering into the ER. All entrances, unless it was an emergency, all entrances were forced to go through the main entryway. Everyone walking through the building and early on was screened for temperature. And, of course, now everyone has to wear masks. So those are some of the things that have been implemented, but I think, one of the major impacts clinically are our clinical students that we really would like to graduate and get into the workforce are having likely to delay slightly their program of study, their graduation, due to suspended rotations across the country. Next slide. For the impact on research, some of the for lack of a better term, not that it's a pro, but you know, COVID has brought many, many questions that need to be answered. And GW, and as well as many of the institutions across the DC region, the DMV, across the nation, there's many qualified scientists and clinicians that have jumped on board and are, you know, ramping up research and trying to get these questions answered. There have been a lot of internal funding opportunities. I know GW has some internal funding specific for COVID projects. There's been, you know, a lot of external government funding that has now been released for COVID projects. So, you know, there's a lot of opportunity to get involved in COVID research. You know, some of the challenges, I'll use instead of cons, it's really challenges that people need to be doing these projects very quickly. And we all know that there are things that need to take place before research can be done, such as various approvals. So any type of project working on human subjects or a project working directly with COVID that's a pathogen would need to be approved by the IRB or IACUC for animals or IBC for pathogenic studies. So all of these approval processes have to be in place. So researchers have to be applying for the funding opportunities, coming up with the types of questions that need to be answered, very rapidly filling out applications for the appropriate approvals before any of this research can be done. And I do know that at George Washington University, our institution-wide committees that do these approvals, for example, I'm on the Institutional Biosafety Committee, or the IBC. We have been having weekly emergency review meetings to review the various COVID-related projects that have been submitted. We normally meet once a month, but we're meeting weekly because we want to be able to approve these projects as quickly as possible to allow our scientists across the university to get started on their important research. So, you know, that puts an extra burden on faculty across the university that are on these committees to, you know, have weekly meetings where they're reviewing large applications. Of course, the lack of PPE is an issue. You know, a lot of researchers want to study this organism and the various aspects of it, but, you know, we can't order masks. They're not, if you don't already have masks, it's very difficult to get masks. And if you're actually working with the organism, depending on what the research is, you'd want to be wearing a fit tested N95 mask. So if you haven't been fit tested or you don't have those masks, it could be very difficult to get that research off the ground. You know, so all of these things have been happening very rapidly at GW. There is a biorepository that has been implemented, and that biorepository is going to be collecting a lot of the, or, you know, all of the clinical samples that are being collected across the university for the various studies, so that we have one repository where individuals can collect samples that they need to answer their research questions. So, you know, as everyone, we've all had to implement all of these things and really come up with all these strategies very, very rapidly. But, you know, when in times of need, we all do what we have to do. And so far, things have been running relatively smoothly. So thank you, everyone. We're all in this together, of course. We'll stay 6 feet apart. And thank you for having me today.
Thank you very much, Dr. Fermani. It's my pleasure to introduce our next panelist, Dr. Sebla Kasai from Georgetown University. Dr. Kasai is an associate professor of medicine and infectious disease clinician at MedStar Georgetown University Hospital. Dr. Kasai, thank you very much for being with us this morning.
Thank you very much for having me, and I apologize for any ambient noise from our hospital that's being built outside my window. So always good to hear about hospitals going up when we often hear about hospitals closing or being in trouble. And obviously these times are clearly very, very different, and I think a lot of the other speakers have spoken about what's happening clinically, what we're doing with regards to safeguarding our universities and institutions during these difficult times. I'll focus a little bit more on some of the issues we've dealt with more from a research perspective in terms of managing cohorts, multi-site national cohorts, and some of the unique opportunities that are unfortunately arise due to this emerging pandemic. So we from an education standpoint, I'll just speak very briefly. We have our inaugural Masters in Epidemiology students that joined came to our campus this year. Unfortunately, they're now dispersed throughout the U.S. And one of our track areas is on infectious disease epidemiology. So as you can imagine, they're learning firsthand as a pandemic is kind of bulldozing through our communities, experiencing this personally in their personal lives as we try to educate them on epidemiology, pandemic preparedness, and they've had great speakers, and we've been very fortunate. Next slide, please. So I'll introduce you to one of the cohorts that I've been working with since my time at Georgetown, and now for about 7.5 years. This is a cohort that preceded me by very many years, a cohort of HIV positive women and high risk HIV negative women that started enrolling in the early 1990s. And this was about a decade after a similar men's cohort, the MAX cohort, started enrolling across the United States. So as part of this multi-site national study with representation across the United States, East Coast, West Coast, as well as the Southern US, we were in this very interesting transition period where we were now being joined with the men's cohort and also switching sponsors from NIAID to NHLBI. So at this time, we've overall enrolled over 4,000 women, are actively following about 2,500 women during this transition period. And obviously it's been a hugely productive cohort. It's made it through multiple rounds of recompetition, and most recently, again, has been combined with the MAX cohort. Next slide, please. And over the many years, what we've managed to do is to really develop a cohort that's highly representative of HIV infection in the US. And I thank my colleagues at our Data Management Center at Johns Hopkins for this slide. We look at it every time we meet at our EC meetings. You can see that we have our racial ethnic representation is very reflective of the national HIV epidemic in the US. So we have a large cohort of African American women, which is very unusual. And again, we've managed to retain this, what is typically described as hard to reach population, socioeconomically diverse population, racially, ethnically diverse population, and maintain and retain these women over very many years through multiple cycles of recompetition. Next slide, please. So most recently, we were tasked with coming up with, a new study to really try to understand comorbidities related to HIV infection. And I share with you here what's publicly available to everybody to find in on our websites and also through the NIH Reporter, are aims that are the focus of our attention for the next 6+ years. And when you look at these aims, a focus on cardiovascular disease, pulmonary disease, neurocognition, aging, psychosocial impacts on health and other outcomes, health disparities, you could easily replace COVID-19 for any of these things, but our timeline is severely compressed into immediate. We need to immediately know the effect of COVID-19 on any and all of these factors. Again, the psychosocial and health disparities components are also highly important, as we are hearing more and more about some of the inequities in terms of the disparate impact of COVID-19 on different and very important subpopulations that are not usually represented in research, and happens to be very much the focus of and the representation of our cohorts within the WISE. And then I'll turn your attention to this last career development of new and young investigators. I think we've heard quite a bit about interruptions in learning, in education, in internships, clerkships that have resulted from COVID-19. And those things similarly can derail new and young investigators who are trying to launch their research careers. But we're still trying to find some silver lining and avail opportunities to new and young investigators, and trying to create very many more of us, because there's, sometimes the work that needs to be done can truly be overwhelming. And so this does create opportunities for junior investigators with the right leadership, the right mentoring. And I think it's incumbent on all of us to find time to bring new people on and to allow them to lead in ways that they haven't had opportunities to do so previously. Next slide, please. So our established cohorts obviously are key, and we were fortunate enough to have been tasked to starting a new cohort of younger women with HIV to answer additional questions that are very important. Again, this particular cohort, we call it the study cohort, study of treatment and reproductive outcomes, just started, and we are in the process of finalizing all of our documents and are slated to start recruitment this summer. As you can imagine, recruitment for this, as well as for our previous study, is going to be very difficult to envision given the situation with COVID-19. I do want to pay special recognition to one of our advisors. We have an advisory panel for this cohort, and unfortunately, Dr. Geeta Ramji, who's a HIV prevention researcher in South Africa, died of COVID-19 last month. So again, this epidemic has had its repercussion both in our professional collaborations as well as personal lives. And again, like this first speaker, I do want to take them a minute to recognize people who have had really devastating consequences from this epidemic. So next slide, please. So our challenges, and again, notwithstanding the personal losses and personal devastation, include delays in study implementation. So I left my office in mid-March, about to start on the inpatient consult service for a week, just as our closures started to ramp up. So I haven't seen that office since, and unfortunately, I have, all of us are able to start up our home offices quickly. My clinic-based office obviously serves as a great resource, but all of my staff had to move off-site, and we were very much an office-focused research unit with plans for bringing people in, enrolling people in person, and doing our every 6-month visits in person, and this all came to a grinding halt. our junior investigators who had funded studies through our CTSA KL2 projects, our DC CFAR pilot awardees, individuals with fixed end dates now had a pause introduced into their work and their plans. And this has been very difficult for us to manage. We cannot do individual in-person recruitment for any studies given the risk-benefit ratio at this time. We've also had delays in agreements that we need to have in place, which again, given, and these are not internal, but mostly external, some of the interactions with our public health partners in both in cohort-related research as well as some of our other research. And this is because mainly of competing interests, other things, people getting pulled in to help with COVID-related activities, and obviously signing some of these agreements gets onto a back burner. And so multi-site collaborations, especially with public health agencies, can be very challenging during these difficult times. Next slide, please. However, there are opportunities which I do want to highlight that are really important, and within our institution, amazing relationships with our all of our research administration has allowed us to really bring on very important studies very, very quickly. So within our existing cohorts, I have to thank my nationwide co-PIs. We are rolling out a multi-site COVID-19 survey, which already has been approved by our IRB. We are having to innovate. We are doing verbal consents. These are our existing cohort members, and so there's a lot of goodwill with those women. There's great trust with those participants, and we will capture, I think, very important information related to their experiences related to this, to COVID-19, as well as some of the psychosocial impacts of having a life-threatening pandemic come through communities in people with pre-existing immunosuppression and a high sense of vulnerability. So I think that'll be really very important. And I have to thank again our ethics review panels who approved that project within, I think, a day or two. We've had other projects come online within 6 hours of us submitting protocols for database type of research. We are participating in multi-site studies of multiple hospitals across the US, gathering data from intensive care patients that we think are going to be hugely informative to what we do, how we manage our cases, and what add to our knowledge from a US perspective, what's happening to patients as they come into our intensive care units. Again, great energy. The organization you have to have in place to start these projects within 24 hours, have IRB approval, within 48 hours, start instructing our very keen medical students about how to look at an ICU flow chart to be able to do excellent data extraction. Having teams in place, having goodwill in place and obviously without the internet, we wouldn't be able to do anything. So having, Zoom, having all of these opportunities to do these distant teachings to allow us to get new and very important studies online very quickly I don't think I could thank all of the individuals in our research administration and our research teams, as well as our students who are willing to step up and help us to do all of this work. Opportunities to leverage existing studies to do biomarker studies. So, we're very grateful for those who do cancer immunotherapy who now want to study the effect of this virus in particular on the immune response and some of the immune catastrophes that we see clinically that we are trying to manage clinically, but with obviously we need a deeper understanding of what's happening in terms of the biology and able to respond in a more appropriate, more timely manner. Next slide, please. So some of the innovations we've had to think about, and a lot of this is thinking through this with our IRB representatives who've been available for quick phone calls with it after a quick email saying, please talk to me about this. How do we assure privacy while we try to increase our knowledge, right? So patients and participant privacy is huge. What kind of innovations are we willing to do? Are we going to do phone-based verbal consents? This is par for the core and permissible if the risk isn't high. For our inpatient, hospitalized patients, are we going to take pen and paper into a room, or are we going to do video or other types of consenting? And how much of this will be permissible? This is going to be an ongoing discussion, and obviously there's going to be a lot of discussion on the ethics of what we do, how we do it, and when we do it, and how we implement technology to help us to be able to do very good cutting-edge innovative research to allow us to have timely information to respond appropriately to this epidemic while safeguarding the public trust as we do research that really is on the cutting edge and sometimes can be difficult and when we have nothing else to offer, so to speak. Accessing patients, again, balancing biosafety concerns and PPE with the need for the kinds of research that we need to do. Accessing space certainly for our outpatient research projects that we hope to do both for prevention and how do we access exposed individuals for prevention. So all of these things are things we're grappling with. Again, a lot of opportunities, really important work that we need to scale up very quickly. I have to say that in all of what we do, the biggest thing that we try to do is try to get to answer yes to any of the asks that we've had to avail ourselves to provide ourselves, our expertise, train our junior investigators to quickly become expert and start leading important studies. And we look forward to being able to collaborate and in this and respond to this global pandemic. Thank you. Next slide.
Dr. Kasei, thank you so much for that presentation and for highlighting some of these critical themes of the effect of COVID across communities that have been underrepresented in research and in access to healthcare. And I know that we'll continue discussion of some of these themes throughout the remainder of the meeting. It's my pleasure now to introduce Dr. Celia Maxwell, our next panelist. Dr. Maxwell is Associate Dean for Research at Howard University and Associate Professor in the Department of Medicine Division of Infectious Disease, and her work has focused on HIV. Dr. Maxwell.
It's a pleasure to join the panel this morning. It's a very significant conversation. I am going to, in the interest of time, quickly try to summarize. If you can move forward the slides for me, because we at Howard have implemented many of the approaches that have been already discussed. As a couple of other institutions, we have a university in addition to a medical school and a hospital. So the university itself has had to make adjustments, definitely with the support of the Board of Trustees, and has transitioned to an online learning so that education provided to our students would not be compromised. So the entire campus, the undergrad, the graduate students, and so forth, are working at home, distance, or the courses have been canceled on campus, so there's nothing happening on campus, and everything is done remotely. because the university recognized that the last several weeks has been very stressful for our students, faculty, and staff. Telehealth, mental health services, and emergency support helpline has also been made available 24 hours a day. Next slide, please. Information is being delivered weekly, sometimes bi-weekly, to the university at large by way of email, video conferencing, online, and other meeting platforms. Unfortunately, our graduation has been impacted, has been canceled, and we are looking to move to a virtual graduation to celebrate with our students the great accomplishment. And so that's pretty much a nutshell for the university at whole. I'll move to the hospital. If I could get the next slide, please. The hospital has proudly served Washington, D.C. Community for more than 150 years. And so to help minimize exposure to COVID-19, all essential or non-essential events have been canceled or postponed. We now have our entrance policy to a zero visitors policy for allowing patients to enter the facility. Next slide, please. The hospital is responding to the challenge of anticipated increasing admission during this crisis. And so we have done a number of things, including erecting a new tent outside the emergency room to triage patients to avoid the backlog that has been happening in the emergency room, and to streamline the triage process to rapidly identify and isolate patients that enter the facility, particularly if they're exhibiting flu-like symptoms. The tent allows us to expand the capacity of the emergency room, as I mentioned before, and it can evaluate patients for symptoms that might be minimal, so that we don't have to see them in the hospital per se. We clearly are emphasizing the importance of maintaining proper social distancing while patients get the treatment that they need. Next slide, please. One of the things that we have done, which is similar to the other members of the DC Hospital Association, is to establish an COVID pandemic task force comprised of infectious diseases physicians, nurses, other stakeholders. And we met and discussed these issues at least 2 or 3 times a week, as well as sending out everyday information that would be important to the staff. While we do not currently have a lab, we are about to stand up a rapid testing hospital lab that's in addition to outsourcing or lab testing, because receiving the results of the lab test has been taking some time, as you all know, and we wanted to get results much more quickly so that we could make decisions about our patients. So we're working closely with the member of the DC Health Association and the Adventist Healthcare to stay abreast of all the resources that's available to us. We have, as mandated by or recommended by the DC Department of Health and Mayor's Office, increase our capacity. Could I have the next slide? Our bed capacity by about 125% in preparation to meet the surge that has been happening, and we're expecting to become more acute as the weeks move on. Next slide. Could you go back one, please? There are a number of things that we are doing on the research end, and I'm sorry there's not a slide there addressing that issue. Right now, we have a collaboration with the NIH looking at our hospitalized patients to see what kinds of host factors might be contributing to the illness or the seriousness of the illness, as we're seeing in many of our patients. We also have a couple of investigators investigating and exploring new pharmacotherapies. We also have availability of funding by GUTS and other entities internally and externally to explore more research as it relates to COVID-19. One of the things that many of our infectious diseases physicians, including myself, have been spending a good deal of time on is addressing questions from the media relative to the disproportionate impact of COVID-19 on minorities, particularly African Americans. What we're seeing is that there is a disproportionate impact of this disease on many of the patients that we see at Howard, not surprisingly, because many of these patients already have severe and serious comorbidities that put them at greater risk. And so in a nutshell, Howard has been moving at a rapid pace to ensure the staff at the hospital with many of the modalities that have already been mentioned. We certainly do have concern about our PPEs. We have been monitoring their use, making them available as needed, but we do have the concern that we will not have enough given the approaching surge. We're offering education to our medical staff, including the residents, the nurses, the clinicians, trying to keep them up to date on treatment modalities so that they can share their experiences. And so, as usual, we at Howard University Hospital and the university are ready or stand ready to be a part of the solution to help this DMV get through these trying times. And with that, I'll stop so that we can have access to some questions.
Thank you very much for that presentation, Dr. Maxwell. And I'd like to thank all of our panelists for really painting such a vivid picture of what preparedness and response looks like across our region. I'd like to invite our participants again to use the Q&A feature to ask questions of our panelists. And as we have just about 8 minutes left for Q&A, and while we wait for questions to come in, I'll take the moderator's prerogative once again and ask each of the panelists what has been most surprising to you or most challenging as you've been involved in your institution's response to the COVID pandemic, something that might be a lesson learned moving forward, if each of you might share that with us. Dr. Maxwell, would you like to start, and then we'll invite each of our panelists to speak to that?
Sure. It has been challenging dealing with patients that have no access to visitors. It's unconscionable to see someone that's really ill and not have the support that they need. And so this is something clearly that I had personally not seen before. And the impact of that, I believe, will be seen down the road a bit, but I think it's a significant impact. So that is something that I was not prepared, that I had not quite seen that way. The impact on the staff, it's hard. Staff are working long hours, multiple shifts, and coming to work every day, but you can begin to see the burnout that this is causing in such a short period of time And I shudder to think what will happen if we have to deal with this at this pace for much longer. So I would have to say the impact on the patient and the impact on the medical staff.
Thank you. Dr. DeBiasi, will ask you to respond next.
I think that I completely agree with what Dr. Maxwell just said. I think one of the biggest challenges for in a time of uncertainty is when guidelines continually change. And I think the messaging and the communication has been critical to that. So if you just continually are just changing your algorithm every 3 days and people are so confused and don't understand why, it's a completely different situation if you accompany that with very good communication. So we found that we tightly aligned any change with a town hall, with a new post on the hub, with an email to each of the chiefs to push it out so that it's all done in an aligned way. That's really helped remarkably, and people are very understanding. It appears to them that it's more organized, which it is, but it makes the implementation a lot better.
Thank you. Dr. Fermani, do you want to respond briefly?
Sure. I think the major challenge, since I'm much more involved in the educational side of things, has been just making very critical decisions so rapidly. I think that's just been something that we have had to learn to do to, get the right people together, make that decision, implement that decision. And I think, that's been a lesson learned of how to make decisions quickly and disseminate that information to all the appropriate parties.
Thank you. And Dr. Kasai, I'd like to invite you to respond.
Sure. So I agree very much with all of the other panelists, and I think communication is, for me, what I found to be so key, and helping to dispel myths and manage fear, both of which are all intrinsic in this kind of epidemic, but channeling information that's very quickly changing in such a way that you continue to bolster morale without looking like you don't know what you're talking about because you just changed everything that you said 2 days previously. So really helping people understand that everything is a moving target, but that everything is being driven with the keeping the safety of health providers, our communities in mind first and foremost, I think is what I've seen as being the most influential.
Thank you. And one last question again, just for a very brief response from each of the panelists. Many of you highlighted research initiatives, some opportunities to either include research on COVID-19 and existing populations with particular conditions. Can I ask each of you to highlight on what you think might be for you or for your institution one of the most important research initiatives that you're looking to explore? And Dr. Kasai, we'll start with you.
Sure. So, just stepping back and really looking at the forest for the trees, and knowing and understanding that we will have waves and to deal with regards to this. Obviously, our treatment initiatives are huge, but I think our prevention our prevention modalities are absolutely imperative. We have to get ahead of the virus before it gets to our communities and to populations that are vulnerable. And so I personally am ready to do anything that it takes to help in that prevention modality, as I support those who are trying to understand the pathogenesis of disease and in treating those who are already infected.
Thank you. Dr. Maxwell, can I ask you to address that briefly as well?
Yes, I think one of the things that we find of great interest and that we are actually looking at now in collaboration with NIH are what are the host-specific responses, particularly for our populations, that makes this such a devastating or gives such a devastating outcome compared to other populations. We would really like to see if we can find what is it, if there is one thing outside of just existing poverty that causes our patients to be at increased risk for a bad outcome from infection with COVID-19.
Thank you. And Dr. Fermani, can we ask you briefly to respond?
I think two key areas. So one that I've seen a lot of proposals come in is, looking at the immunological response of various patients and populations. So that's a large research endeavor at GW, and also getting this biorepository together so that all of the patient samples can be in one place for easy access.
Thank you. And Dr. DiBiasi, if we can ask you to respond and have the last word for this panel.
Yeah, I think the most exciting thing is this concept of pulling together multiple databases into a unified data set for the institution, and thinking creatively about how we utilize access to a biorepository that has limited samples, how we can leverage that to not necessarily think about each investigator needs a sample, but they might need a similar data set to maximize the type of studies that we can actually do. So I think those kind of meta research organization is really exciting to me, and I think something that we always, hope that we could do, but I think this has really accelerated it, just as COVID has accelerated telemedicine. I think this has been a benefit to the research community.
Thank you very much. I think that's a wonderful segue to our next panel about research data management and research sharing, as you're alluding to. And I want to thank each of the panelists for the work that you're doing and for your leadership during this time of the COVID-19